All right. Big, large group. Hope you have enough space. My name's Amy Connery. And just real quick, can I ask like what people's disciplines are so I know how much background and things I'm going to be explaining about assessment? Okay. Okay.
We both specialize in pediatrics.
And do a lot of assessment, I'm sure.
Yes. I'm an administrator. I did work in surveys, like collecting data previously in public health related programs, but currently not in any assessment role. Yeah.
Okay. And you too.
Public health student.
Yeah. Okay. So today I'm going to be talking about challenges to neurodevelopmental assessment in low resource areas, and I'm going to present data on how we implemented a neurodevelopmental testing program in rural Guatemala, and I'm going to present some of the preliminary data. And why this is important is because often when we look at developmental problems in parts of the world, in low or lower middle income parts of the world, they're looking at rates of stunting and poverty, and they use those as proxies for looking at neurodevelopmental problems in kids. And the reason is that because we have no data. A lot of the times there's no data. And there's no data because there's no, I shouldn't keep doing that probably, right? There's no data because there is often no existing test for people to use, and there's problems with personnel, that people can't find the people to actually administer those tests. But the problem is that if you don't have rigorous objective developmental data at the individual level, then you're really limited in your ability to identify children who are at risk for neurodevelopmental problems and to understand the impact of specific diseases and exposures. So today I hope to convince you that it is possible to obtain high quality, rigorous, objective developmental data. And this is the data that is necessary for advancing the science on the effects of poverty on young children. So this data was part of a larger study we began in 2016. It was a collaboration with Baylor and Emory University, and to look at postnatal Zika infection. And interestingly, I'm actually not going to talk about Zika today. The reason being we didn't have any cases of congenital Zika syndrome. We don't believe we've had any new cases of new postnatal infection, and a lot of our lab results are still pending. Actually, we should get a lot of it tomorrow at noon. But we don't think that Zika has been a major driver, especially in our youngest children. This study took place, many people know here, that the University of Colorado Research and Clinic site in southwest Guatemala that was started by one of our infectious disease docs here, Edwin Astorius. And the community has anyone been there, aside from Desi? The community is monolingual Spanish speaking. The region is endemic for Zika, dengue, chikungunya, CMV. There's high rates of child mortality and morbidity, and really all the things that come with living in poverty. The goal of our study, and this is the picture of the center. It's funny, you're like in the jungle in the middle of nowhere, and then you pull up and there's the balloon boy and a see you buff sign. It's a little funny. The goal of the study was we were going to enroll over 800 children ages 0 to 5. We were going to enroll babies, siblings, and community controls. And then we were going to evaluate them, do neurodevelopmental testing at 2 or 3 time points during a year, depending on their study cohort. So this was obviously a huge, huge undertaking. We were going to test over 2,000 times in a country where we were not sure there was an existing test, and we were not sure we were going to be able to find the personnel with the expertise and background that we could train to actually administer the test. So because of that, we did a lot of reading and research to figure out, like, well, what are the decisions we need to make, and how do we make the best decisions? And this is important because neurodevelopment is the outcome. So we had to be, this is a thing I'm going to come back to a lot of times during this talk, is we can't give short shrift to thinking about how we're going to get good quality of data if neurodevelopmental data is the outcome, right? So we can't just, we can just do this, right? It's not quite that simple. So what we did was we created this decision algorithm. and looking at breaking down like what are all the steps we took to make this decision. Because if you dive into the literature, you will not see this. People don't tell you what they did. They don't tell you how they translated the test. You don't know how they trained their personnel. I mean, there's inklings of it in some places, but there's a lot of secrecy about how this is done. So we wanted to be very clear about the decisions we made. And I'm going to go through them real quickly here. So the first is the obvious question is, well, what do you want to study? What is the construct under study that you want to evaluate? What is the age range of kids, the number of kids you want to evaluate, and then considering feasibility and efficiency. So how long is it going to take to administer every test? And then do you have people with the expertise to select the correct test? And for us, that meant neuropsychologists here in the US consulting with psychologists in Guatemala about what was available. And then the next consideration is what kind of evaluator you're going to have. So performance-based testing requires a pretty high level of an evaluator. You can give an IQ test, for example. I mean, parent questionnaires are a whole other level of, being something easy to administer. But if we're talking about performance-based testing, something you administer to somebody to see how they do, you can give an IQ test to a school-age kid. It's pretty easy. It can be like a bright person could pretty much read the manual and then know how to do it. So it's pretty straightforward. Performance-based testing of young children is much, much, much more complicated. So the bar must be higher for what we're going to expect of the person doing that training. And the reason is for a few things. One is that most school-age kids will sit in their chairs. They don't cry during the testing. They don't take naps. They don't get fussy and want food, right? So there's lots of things that make it difficult. You have to keep adjusting how you can't, most school-age kids, almost all the time, I administer things right in the order that I had planned. And with a baby, I almost never administer things in the order I had planned. Because suddenly they're on the floor. And then I think, oh, okay, now I can start gross motor. They're on the floor. And then or they need a break. And so then I have to, or they're fussy about this certain item. So I'm going to switch to this stuff, wait till they get calm again, and then switch back, right? So it requires that the evaluator understand the test so well that they know when they're moving out of the standardization that they're still maintaining standardization, that they're still testing what the test is supposed to be testing. So it just requires a much higher level person. And if you're feeling like, okay, well, we don't have anyone on our team to train them and we're not going to be able to get that in the country that we're working, then it makes much more sense to say, okay, well, let's use a developmental screener, or let's use a parent questionnaire or something like that. So then you want to know, is there an existing test that you can translate and adapt? And if there isn't, where am I here? Sorry. If there isn't, you have to consider, like, do you have the time and resources to develop a new test? So that will take years, typically, with people with, biostatisticians and all these people, and often doesn't make that much sense to do that when there are psychometrically strong tests available. This is more applicable for the youngest kids. We have more universality in development of young kids, right? Healthy kids walk at the same time throughout the world, talk at the same time throughout the world. We're not as the issues of culture do not get as complicated as they do as people get older. But then if you think, okay, well, we have an existing test, we can translate and adapt it, then you have to think about, can you hire the team to do this work, which is not a bilingual person. Like, that's not enough. So and this happens all the time, where somebody says, oh, they hire somebody who speaks both languages, and they hand them the manual and the protocol and ask them to translate the test, and they just do it word for word and hand it back and call it good. And I'm going to talk about why that's a problem. You have to then then you have to obtain permission from the testing company to translate it. So for us, we bought 4 testing kits. So that was probably, over $5,000. And then we paid over $2,000 to the testing company for the permission to translate the test. And then we still had to pay them. So then the protocols we were using were not their protocols. They were the translated ones that we made. And we had a fee for every protocol we used too. So there's many problems with this system. One is that a lot of people don't do this. They just translate it on the down low. And so when you're trying to ask those teams, like, well, how did you get this data? And what are you doing with your test? They don't want to tell you because they don't want to raise the awareness that they didn't pay Pearson to be able to do it. The other huge problem is that Pearson, I keep saying Pearson because they own almost all of our tests. Pearson doesn't tell you if somebody else has already done the work. So if your team moved into Trujillo, where we are in Guatemala next week, and called Pearson and said, we want to use the Mullen, can we translate it into Spanish? They would say, okay. They wouldn't say, oh, there's a team there. They've already done it. They've got 4 papers published on it. So this is a huge problem. So then you're taking teams that have limited resources financially and otherwise, and you're burdening them with this work that has already been done. It's like totally ridiculous. So on my to-do list this spring or summer, when things might calm down a little bit more for me, my hope is to get a group of pediatric neuropsychologists, psychologists, developmental pediatricians, people who are doing assessment, domain-based therapists from around the world to get a petition going for Pearson to try to eliminate this, improve this process. And so what my thought would be is saying, will you make tests available in low and lower middle income countries, and there's no fee, and they keep some record of where something was translated, how it was translated, and are there publications showing that it's working? That would be so simple for them, right? They wouldn't make as much money, but they're not making it much now because it's easy to fly under their radar. Okay. Then the last decision is an important one about what to do about norms. So if you're going to diagnose developmental delay or diagnose children you want to compare them to kids across the country or across a big region or globally, then you need a big, wide normative sample that's representative of that group. And if you're going to diagnose neurodevelopmental delay, you need healthy kids in that sample, right? To say, well, this presentation is not healthy, and I'm comparing it to healthy kids. A lot of us doing global health work are not doing that, but what we're trying to do is to compare children within a community to isolate the effects of some specific disease or condition, right? So, for example, in Trujillo, when we're looking at microcephaly, and we want to isolate, like, is microcephaly specifically adding some additional risk? Then if we compare them to healthy kids, we're not controlling for all of the things that come along with living in poverty. So we want the kids we're comparing to be in the study living under the same kinds of burdens as as all the children are. So that is what we did, and I'll show you as we go. I'm going to diverge a second to going back to this idea of when diagnosis is the goal. So when you're going to say, this is a developmental delay, this is how we would understand this globally, this is a problem. And a few years ago, we were put in a group, some developmental pediatricians from children's and some neuropsychologists, and we worked with a group of 30 international experts on child development and assessment. And we were working with this group called GAIA, which is I have to write it down because I can never remember it. Global Alignment for Immunization Safety Assessment in Pregnancy. It is a long name. But what GAIA is trying to do is really interesting. They're trying to make sure that they're monitoring adverse outcomes after pregnancy, after immunization in pregnancy. And they want to monitor that globally. So to do that, then they have to be speaking the same language about, if this is the adverse outcome, are we talking about the same thing? So if you're saying this is microcephaly in Uganda, does that mean the same thing for me with microcephaly in China? Does that mean the same thing about microcephaly in Guatemala? Okay, so they have put all these teams together around these different conditions to create the structure of diagnostic certainty. So like, what things would you need to have increased levels of diagnostic certainty? So for a lot of their medical outcomes, for example, it's about instrumentation and timing of measurements and things like that. And for our task was, what do you need for high levels of diagnostic certainty when you're testing young children? And you can see that it got complicated. And we really looked at two things that we decided were equally important. And I again would say that this is neglected in global health research. The psychometric properties of the test, but the second thing, equally important, was the personnel. Who is giving the test? So we defined the properties that would meet a gold standard criteria, below gold and well below. And I would say that developmental screeners, caregiver reports are never going to meet that highest threshold. So that's still often like a thing to do and a feasible thing to do, but recognizing that there are a lot of limitations then to the quality of that data. So equally here, the team decided that when you're doing 0 to 5, the person giving the test is equally important to the quality of your data. And so if you see the gold standard is somebody who's fluent in the native language, obviously, who has the highest level of training defined by that country, right? So in Guatemala, that is a bachelor's degree, whose training is much more like a master's degree. In the US, the psychologist has a doctoral degree, so defined by the country. And then you could also have specific domains, so language domain by a speech language therapist, the motor domains by a physical therapist, so a domain specific specialist would also meet that criteria for the gold standard. And then there's this complicated system of, well, what would be that level 1? And you can see that you couldn't get to that highest level of diagnostic certainty without a performance-based test that was psychometrically robust and a high-level person administering the test. And I think most of us, I don't think that is a hard argument to make to people who do young child assessment. And one last thing about that. So I would say again that when this part of it is neglected in global health research, you sometimes hear people say, oh, we were expecting this outcome and the data didn't show it. And sometimes that's just about how hard it is to isolate the effects when kids are under so much burden to their development. But sometimes I think it's this issue that the data wasn't high quality enough to pick up these more subtle things. So what we did from looking at all the things that we needed to do for our study is decided to do the Mullen scales of early learning. And so, hi Steve. So if people here are familiar with the Bayley is the most widely used infant developmental test here in the US, but certainly globally too. The Mullen is not as well used, as widely used. We decided to use it for several reasons. The Mullen covers the whole age range of kids in the study. The Bayley goes up to 3.5. The kids in our study were up to 5. So if we had used the Bayley, it would have required us to use 2 tests and then be trying to compare 2 tests, which we thought would just be much too difficult. It covers all the major neurodevelopmental domains. And we were going to give it over 2,000 times. And so the Bayley, it takes twice as long. And so that was a very, very important decision as well. We did not have time to create a new test. We actually did not think that that made any sense, given that the Mullen is well established, it's psychometrically strong, and that there is a pretty strong literature on the ability to use an existing test with young children in a country that was developed in a higher income country in a lower resource area if it's carefully adapted and translated. And then we knew we would be able, at that point, we knew we had the team to do that work. So Desi was one of them, and we had this amazing team of Guatemalan psychologists. And then with 2 of us here at the university, we knew we would be able to do the translation and adaptation work. And then lastly, we knew we were going to do study created norms because we wanted to be looking at Zika in the community, microcephaly in the community, stunting in the community, and that we didn't need a wider regional norm base. So this was the team. We had again, thinking about why you wouldn't just hire a translator and send them the Mullen in the mail and have them send it back in the other language. It's because you need content experts, you need cultural experts, you need people native and fluent to your target and source languages. So for us, native in Spanish, fluent in English, native in English, fluent in Spanish. And then, so there was 5 of us, and then we did a lot of consultation with local research nurses and MDs here and at the site too, asking like, does this make sense? And how would you answer this? And trying things out, piloting things, changing it as it worked or didn't work. And here is an example of what we did. So there's a question on the Mullen which asks the child to repeat the sentence, in the winter, we go sliding down the hill on our sled. So this would be obviously profoundly ridiculous to ask a 3-year-old to repeat. And when the content is harder, then it is harder to repeat, right? So if I said that sentence to you, you could repeat it fast. Now, if I was a physicist and said some long, sentence with complicated physics words and equations, it would be much harder to do, right? So when you make the content harder, then the item automatically becomes harder. So we changed the content to make it similar in concept, but not unfamiliar. So we changed it to en el verano bajo la montaña en bici. So that means in the summer I go down the hill on my bike. And then the other important thing we did was, this is a working memory task also. So what can you hold in mind? Well, your working memory is really sensitive to the amount of verbal information that is in your mind. So if you increase or decrease the number of syllables in the translation, you've changed the item level difficulty. So we sat there in hotel rooms and clinic rooms, like in el verano, counting to make sure that every time we made this kind of change, it matched the number of syllable for syllable. It was really fun. It was fun, actually. So the study is in a large geographical area, and this is an issue that you'll see repeatedly spoken about in global health, that people will have a study plan and nowhere to test. There's no clinic, there's nowhere to test. And we have a clinic, but a lot of families couldn't travel to it, and so we knew we were going to be needing to test in a lot of different places. So part of the way that we trained the psychologists was in this issue of how can you maintain standardization in wherever you are, whoever is watching. So how can you be very flexible, but get high quality data? So we tested in our clinic, we tested in health outposts, we tested in the home with large audiences, as you can see. And then we tested on this converted bus that we had. And then we did statistical analysis to make sure, and there were no significant differences in performance when children were testing in these different spaces. And then we wanted to know, is it working? So let's take a look at the Mullen statistically and make sure it's doing its job. So one of the first things we did was this very tedious task we did with inter-rater reliability. So we had the psychologist, the Guatemalan psychologist would give the Mullen, and another one would watch and live double score it. And then we did the same thing. One of the psychologists would give it, and then one of us from CU would live double score it. And you can see we had excellent inter-rater agreement. And again, this is notable. If you did this on an IQ test of a school-age kid, it would be 100% agreement because things are right or wrong most of the time. And in babies, it's like, was that the sound? Was that duplicated babbling? Was that reflexive? Was that on purpose? Right? There's much more nuance. We then looked at internal consistency reliability. And so we took those kids that we double scored and we looked at every measure. And what should happen on a developmental measure is the items are easy and then they get harder. So you should not see, all kids can be a little scattery, but you shouldn't see a lot of scattering of scores. Once they're getting them right, they're getting them right. Once they start getting them wrong, then they should be petering out pretty soon after that, okay? So it's showing you that you've got easier to harder items. And so those look good. And then we looked at retest reliability. So we looked at Mullen scores at enrollment and then 1 year later. And again, you see nice statistical significance here. This is my favorite of these charts. This is looking at over. Yeah.
not sure I understand test resets reliability, because after a year, isn't it possible that the child will be different in terms of how they test? I mean,
but it always accounts for their age, right? So if you were 1 at the beginning of the study, and it's controlling for your age, so what is a 1-year-old expected to do? And say you stayed on a good developmental trajectory, you gain skills, so you look very different than you did at 1, but your standard score, when it's adjusted for your age, looks the same.
Except if their trajectory, instead of being a normal trajectory, is not a normal trajectory. So
right. Well, we had more kids because the babies, cohort B, as you know, Steve, they were just going from 0 to 12 months. So we weren't seeing that big decline in that age range. And then
but you could see it from 1 to 2.
Yeah, and it's not that dramatic in those ages, kid to kid. As a group, we're seeing it. And then once you start getting into, you'll see on that next slide, like 2 to 3 to 4, it all stays low. So this is over 1,900 records of the Mullen, and this is raw scores. And what you can see here is that raw scores increase as the child gets older in every domain, like very, very beautifully. And so what it's telling us is that kids are making developmental gains, right? And that the test is capturing these gains, and also that the test is maintaining item level difficulty. Because again, if we had that bouncing around, we wouldn't see these nice scores coming up as kids got older. And so, as I've been saying, this is what we use when we do any analysis. We use raw scores and we control for age. But I'm going to show you real quick what it would look like if we used the American normative sample. And so what you're looking at here is the American normative sample, the kids from Trofino compared to them. The orange bars is a composite score of 4 of the scales. So the 4 scales aside from gross motor. And that has a mean of 100 and a standard deviation of 15. So there you can see those bars are up higher. And the bars with colors are the domain scores, and they have a mean of 50 and a standard deviation of 10. And so what you can see here is, I think, to what Steve is referring to is this thing that we've been talking a lot about over this last couple years, is that kids are tracking along with the American normative sample through that first year. And then we see a dip in scores, and that the scores are staying low, 2 to 3 standard deviations below the American normative sample, then throughout. This has been replicated all over the world, and there's probably a few things happening. One could be that maybe we're not picking up on the delays very early, right? There's just not as many expectations. When you give a test to a 3-month-old, there might be 3 or 4 questions in every domain, right? So maybe we can't just discriminate really, really well because of some limitations in our test in the youngest kids. And or the other thing would be that the developmental demands on a 3-year-old are much, much, much greater than they are on a 1-year-old. So a baby that might not look different from another baby, and then by the time they're 3, and the healthy baby is walking and running and having conversations, and the other one hasn't kept pace. And then the last thing that I would suggest is probably at play is this issue of cumulative risk, that we know when kids live in communities with high burdens of risk to their neurodevelopment, that those risks are cumulative and layer on top of each other, so that the older that they get, they've had more time to be exposed to infections, disease, growth faltering, and things like that. And then the last thing we looked at was what we call criterion validity. So we took a well-established Spanish language test. It's called the TVIP. If anyone knows the Peabody, it's the Spanish language Peabody. And it was normed in Puerto Rico and Mexico. You show the kid 4 pictures and you just say, where's the dog, where's the table, where's the doll, like that. You can give the TVIP to kids 2.5 years and up. I've done that very regularly here in the United States. I've never had a kid not be able to do it. But we were thinking this was going to be hard for kids at 2.5 years. So we decided we would start giving it at 3.5. Most interesting was that 19% of kids failed the practice items and we couldn't give the test. So, and there's teaching that happens in that too. And so this was as simple. This is the first page, like, where is the dog? So 19% of kids couldn't do that. That is alarmingly high and exactly the rate that was reported from a big World Bank study where they looked at this exact thing. They looked at single word receptive skills and children in rural Guatemala performed. This is exactly what they reported from that study. But in terms of what we were doing with the Mullen, performance on the TVIP did correlate well with the receptive language portion of the Mullen. So it gives some more evidence that the Mullen is working and is measuring what we're purporting it to measure. Okay, so I'm going to talk about some preliminary. Do you have a question?
No.
Okay. Some preliminary outcomes.
Can I ask you one question before you move on? No.
Yeah.
Can you go back? I think it's 2 slides, right? Yeah.
Yes.
So why do you not have any gross motor T-scores after 36 months?
Good question, physical therapist. The Mullen stops testing gross motor at 33 months.
Oh, that's okay.
Yeah.
Okay.
And I think, in the U.S., it's probably like, okay, I felt like it was kind of a bummer that we didn't have it then after that.
And so even if a child had delays in their gross motor development, you just didn't do that portion of the test at all? Okay.
A lot of the vast majority of those kids got follow-up from neurology residents and our neurology telehealth. But there's no way to test them.
Okay. And one more question.
Yeah.
So their fine motor skills between 12 and 18 months look to be considerably higher than any other age bracket. Do you have any?
Between 6 to
12 to 18 months.
Yeah.
The fine motor, the green bar.
Yeah.
Is significantly, I don't know about significantly. It looks higher to me. Than any of the other age brackets. So is there any thought about why that might be?
I haven't looked at it that closely, actually, I will admit. So, but that is interesting. We would have to, my guess is it's something about sample size. That group might be large because there's 2 cohorts in there, in that group. But that's interesting. We'll look at it and see if it's sample size or something else.
Okay, because
that would be driving it
quite a bit after that.
Yeah.
Okay.
And it's below in front of it too. Yeah. Okay, so we're going to talk about some preliminary things we've looked at within this neurodevelopmental testing. And the first one I'm going to talk about briefly here is stunting. So stunting is defined as height or length for age that's 2 standard deviations below the WHO growth standard. We think that stunting is multiply caused, that there's recurrent GI and other infections related to poor hygiene, contaminated food or water, inadequate nutrition, which could be insufficient quality of food or eating food that lacks nutritional quality, and then maternal factors including the mother's nutritional status before, during, and after pregnancy, short birth spacing, age of pregnancy, and likely inflammation plays a role as well. And as I have referenced, these causes are often interrelated and cumulative. So we believe that the undernourished kid is vulnerable to illness. They get sick more often, and when they're sick, they're more likely to get undernourished.
You know, is breastfeeding, is that pretty high in regards to the rate of breastfeeding in Guatemala?
The rate, it's not high in compared to other parts of the world, I don't think. In our community, it's about...
It's very high because there are no alternatives.
Okay.
But it's still through about 6 months, right? It's still through about 6 months, right?
But most, Desi may know, I think we looked at that, and most mothers breastfeed.
For the first 6 months.
Yeah, for at least the first year and sometimes longer.
Yeah, I'd say between 6 and 9
month.
Yeah, because I think we think that this is actually a project Desi's working on to look at the role of breastfeeding and stunting.
Okay.
And so we haven't seen all that data, which we're actually supposed to see next week. But I think that complementary food is often introduced at that 6-month period. That's not
I'm
exclusive.
not sure. My understanding, Desi, was that people introduced complementary food, but they didn't stop breastfeeding.
Right. But the introduction of complementary food is the first time point where you can start to see stunting occur because you're introducing not clean water and other kinds of contaminants. So that is, we'll have some good answers to that pretty soon. But when you look at the research on breastfeeding, it is tied to when the mom stopped breastfeeding. Yeah.
And like formula isn't really a push issue, I guess.
Not right now. I mean, it was in the 80s and stuff, but yeah.
Sorry.
Yeah, no. Okay. So if you look here at the global prevalence of stunting, this is from UNICEF, you can see that it is a huge, huge problem globally, and that Guatemala is the only country in the Americas with this really elevated rate of stunting. And so for me, again, this says something about like how much we don't understand, because in terms of just economic progress, does Guatemala look really different than Nicaragua and Honduras and El Salvador? I would argue no. And so I think there's probably some specific things happening in Guatemala that we don't fully understand. So when we looked at stunting in our community, in our study, we took children that were 9 months to 30 months. And this was for a few reasons. We also wanted to look at head circumference, and we didn't have head circumference data on anybody over 36 months. We just took it for 3 years and younger. And then in that youngest cohort, we wanted to take their oldest developmental testing, thinking about this issue, like, well, can we get the best discriminability on the test? Can we get better discriminability if they're 11 months versus they're 1 month old? So that's why we chose this group, and there were 578 kids in this group. And there was an overall rate of stunting of 37%. And then you can see that the little guys, it's 33%, and the bigger guys, it's 47%. And again, that's something that is talked about pretty frequently in global health literature, with the rates of stunting increasing as children get older. And so then what people always say, and what you might be thinking too, is like, well, aren't Guatemalan people small? And you're just taking the smallest people, measuring the smallest kids in a community of small people. But what we know about how children grow is that when they have enough food to eat and clean water, and they're not living in conditions where they're getting repeatedly ill and growth faltering, that they grow very similarly around the world. And this is the study most often referenced from that. This is the WHO Multi-Center Growth Reference Study. They looked at over 8,000 kids from all these different countries, and these were low-risk samples, so kids that had adequate food and stimulation, clean water, all those things. And what they determined there was that, they said, importantly, a single international standard for assessing the growth of all children embodies the very powerful message that when health and key environmental needs are met, the world's children grow very similarly. The other reason that we know the growth parameters mean something in our sample is because kids who met criteria for stunting did worse on neurodevelopmental testing on almost every domain than kids who did not. We then we saw a lot of different growth patterns over the years, so we wanted to break that down and look at that. So we looked at acquired stunting, so kids who did not meet criteria for stunting at the first time point and did at the second. Resolved, they met criteria at the first time point and did not at the second. And persistent, where they met it at both time points. And keep in mind, like, this is like total arbitrary cutoff. You could be negative 1.9 and we put you in resolved, right? So it's still like we're trying to figure out, like, well, what are the best cutoffs that have clinical significance? And these real crude ones that we had used initially do seem to be working. So if you can see here, then when you compare kids to healthy kids or kids who did not meet criteria for stunting, this persistent group is really the group that stands out. So what it tells us is that stunting may need to be present and unresolved for some period of time before we can start seeing neurodevelopmental effects. And it also tells us that there may be some time frame where things are reversible, right? That we don't have to say, oh, the child is stunting, oh no, it's over, right? That we know that children are still growing and changing so much in those first couple years of life. Okay, I'm going to talk a little bit about microcephaly. So as people know, microcephaly is thought to be a proxy, the size of the head, a proxy for brain volume. So an indicator that something has gone wrong with brain development. And it's typically defined as small head circumference, so 2 to 3 standard deviations below the mean, with 3 standard deviations below the mean being classified as a severe problem. And up here, you can see all these definitions of microcephaly, and this is from a paper that Anne-Marie Rick did at the Global Health Center with several of our colleagues there. And a lot of times you'll read a paper and they'll report a rate of microcephaly, but you won't know what definition they use. And when Anne-Marie plugged all our kids into all these different definitions, she came out with wildly different rates. So it's really important, like, well, what growth chart makes sense? There's challenges here in lower income countries because you don't always know the gestational age, and the gestational age is considered in many of these definitions. Births are not always attended by a skilled birth attendant who puts a measuring tape around the kid's head when they come out, and there doesn't always, child's not always getting well child checks where those measurements are documented. And even nutritional studies don't always consistently include a head circumference. So it's quite challenging. When Anne-Marie and the group at the Global Health Center looked at rates of microcephaly in our population prior to and during the Zika outbreak, you can see those rates were quite high, telling us that something else was happening that was not just Zika. And the rates were 3 to 4 times higher than in Brazil and more than 10 times higher than in the US or Europe. So why is this? So most studies on the incidence, causes, and clinical significance of microcephaly have been done here in the US or in higher resource settings where there's availability of resources. So a child has a small head circumference, they're getting an MRI, they've seen the geneticist, they've seen the neurologist, and even with all the resources and testing we have, 40% of the time we still don't know why a kid has microcephaly. But in low-income countries, certainly where kids often do not have access to those specialists, then we really have no idea what's driving it. But because the rates we believe, are so much higher than we're seeing in higher income countries, we have to believe that there are other factors driving those rates up that we're not seen in high income countries, like nutritional deficiencies and congenital infections and things like that. And why do we care about the size of the head? Because we think the size of the head is a proxy for brain development. And we know that in high income countries, microcephaly is known to have increased incidence of developmental delay and intellectual disability. But again, in low-income countries, the paucity of data, there's either small sample sizes or there's uncertainty about how applicable the growth chart was. And then much more often, there's no neurodevelopmental data to show, like, well, was this significant? So they might report like, oh my gosh, we have 40 kids that met criteria for microcephaly. But then if you don't show, like, well, it means something clinically, then you're still scratching your head like, was that the right growth chart? Maybe they just classified kids wrong. So that's the debate. That's a really hard problem. And we're working with people in the Global Health Center with a group, an international group, to try to write a position paper on microcephaly and write a paper on, like, okay, well, what are the problems with the growth charts and how do we speak a common language and what are the things that we need to do to really understand this problem better? This is that same group of children, 9 to 36 months. And you can see, again, very elevated rates of microcephaly, pretty similar among the ages, 17%. And in the little guys and 16% in the bigger guys, and a much smaller group meeting criteria for severe microcephaly. So we really haven't been able to look at differences between that moderate and severe group because that severe group is just so underpowered. But if we look at them, oh, and I should say something very important, we were struggling, like, well, what growth chart are we going to use? Like, we don't know the gestational age. Kids were enrolled in our study when they were 1 month old or 2 months old. And how are we going to do this? Are we going to estimate it? And we thought, well, let's just start with the WHO, and we'll just use like the simplest growth chart we can use. And if it doesn't seem to be working, then we'll use something else. So this is with WHO. So then if you take those kids that we classified with WHO without knowing gestational age, you can see that in almost every domain, they do worse on developmental testing than children whose heads were not classified as microcephalic on those WHO growth charts. Okay. And then there's all sorts of talk about microcephaly subtypes, like was it congenital or acquired, which is a question we couldn't answer most of the time because, again, we didn't have that birth data. But one of the things we wanted to look at was proportionate and disproportionate. So this is something that's talked about a lot too. So, and people will call it absolute or relative and absolute. So proportionate meaning the head is small and the body is small. By definition, that means you're stunted and microcephalic, right? But the argument is, well, you're small. Like, there's no problem with your head if your body's small too. If it all matches, that's no problem. And then disproportionate is your head is small, but your body is of normal size. That's the kind of what we talk about more often than not when we're talking about microcephaly here in the U.S. So oftentimes studies don't separate the two, so it's hard to know, but there's definitely people who say if it's proportionate, that's just the whole body small, so the outcome should be less severe than in disproportionate. But I think this is totally unsettled in global health research. So we then looked at at proportionate. Did I present that? So looking at that real quickly, more kids in our study met criteria for disproportionate microcephaly, and then we had a proportionate group too. So I'm going to show you how we kind of analyze it, but you'll see that once we're breaking it down to that level, we have some really small sample sizes too, which we think are interfering with our ability to really understand what's happening. So in that little kid group, 9 to 12 months, proportionate microcephalic versus normocephalic kids. And keep in mind, the normocephalic kids could include also kids who are stunted. So we're just talking about head size in that group, normal head size. And you can see that the scores are clinically significant, that those kids did worse on developmental testing than the normocephalic kids. We didn't see that for the bigger kids, but you can see that all the scores are trending in that direction and that it's really underpowered. There's only 11 kids in that sample. And so my guess is that that's what the problem is there, that it's just underpowered. And then we looked at disproportionately microcephalic with normocephalic kids, and we did not see clinically significant differences in the baby group, and we did in the older group. And our hypothesis for this one is that we have a little bit better sample sizes, and for sure in the babies we've got 47 kids in that group, but that some of the limitations again of testing at those young ages, maybe it's taking the 2 hits for us to be able to start to see it. The 2 hits of stunting and microcephaly, where we can start to see these neurodevelopmental problems, and with 1 hit we can't quite see it yet. Those are our hypotheses, but as you can tell, it's complicated. Okay, I'm going to go. I know I have a few more minutes. Yeah.
This is terrific, but I'm a little bit confused. If someone was stunted, and they were -2, and they were microcephalic, could they have fit into either disproportionate or proportionate based upon what were they called?
They were called disproportionate, or they were called proportionate. If you were 2 standard deviations below body and head, they were called proportionate. And then if their body was not 2 standard deviations below, but their head was, they were called disproportionate. But again, like we did look at it continuously and with continuous variables, and it looked the same. But again, you could have a body that's 0.19, and we called that normal because it didn't meet the cutoff.
So, of the children that were stunted, about what proportion of them were also microcephalic?
So that was,
well, because where I'm going, what I'm trying to find out is if you compared it to normocephalic children, but if you were stunted alone and you had stunting and microcephaly, how did those compare? So, trying to tease out these cumulative risks.
I know. We have sat in the conference room, like banging our heads against the wall to figure out the best way to do this. And that will be something that we're going to look at soon, of trying to look at all the, I'm just pressing buttons here, all of the different ways that we can tease out when stunting starts to impact development, when it needs to be microcephaly too, and what is the neurodevelopmental impact of having those two hits. And then again, and where's the cutoff where we start to see clinical significance? Because maybe for us, we need to change the cutoff to negative 1.5 or negative 2.5 or something like that. So it's all in progress. Rest assured, Steve will have it at some point. Okay, I know I have a few more minutes, but I'm just going to talk quickly about caregiver report. So we also administered a test to caregivers called the PEDS-QL. I don't know if people know it. It is the most widely used caregiver report measure of health-related quality of life. It's just a quick questions about energy and social functioning, and looking at, are the health problems of the child impacting their functioning in daily life. The PEDS-QL is very widely used globally. It's for sure the most widely used health-related quality of life measure. We had a version of it from Mexico, so we had to make some minimal regional language changes, but not that much. We did not want to make determinations about whether a mom had the literacy skills to read it or not, so we read it to everybody just to be consistent. And then the PEDS-QL has a Likert scale of 5 responses. So if you're reading it to somebody and then they have to hold in mind 5 responses, that's pretty difficult. So we created a visual Likert scale. This went through many, many, many versions that did not work. And this is where we landed. And Guayo, one of our nurses, who's an artist, also made this for us. But this seemed to help, this idea of never being the positive thing, and almost always covered in mosquitoes. So that helped parents kind of figure out how to answer the questions. If we look at all the data together, so this is 3,385 PEDS-QL administrations, a massive amount of data. And we look, stunted kids looked worse on 2 of the 3 scales than healthy kids. And kids with wasting, which we think is a metric of acute undernutrition, did not score worse than healthy kids. It should be working for everybody. It is not. If we look at PEDS-QL data then at specific time points and not all together, cohort B is the babies, A and C are the toddlers, we can see things look much more random. So we're looking at statistical significance, and we're also looking at something that we call the minimally clinically important difference. So this is the difference that would be, you'd need to see in a raw score to trigger some different response from the caregiver. And you can see that it's a little all over the place. Some things were statistically significant, some weren't. And so what this tells us is that if you only had a single time point or you had a smaller sample size, you might not be able to achieve reliable results. Like if you happen to give the PEDS-QL at that 12 months, you might say, oh, look, it worked. You know, the healthy kids look better than the stunted kids. But if you had given it one time at enrollment or one time at 6 months, you wouldn't have. And that feels true to our experience there, that there was a lot of random responding. There was a lot of responding that was inconsistent than what was reported in interview. And so we think that there's something specific happening with caregiver report in our community that we don't understand yet. So in sum here, our data demonstrates support for the idea that when tests are developed in high-income countries, they can be used in lower resource areas when they're carefully translated and adapted. We've not shown good evidence for the PEDS-QL as a reliable indicator of health-related quality of life, suggesting again that there might be some specific issues around caregiver report in our community. There's high rates of stunting and microcephaly in our sample, which are associated with poor neurodevelopmental outcome. And this relationship between stunting, microcephaly, and neurodevelopmental outcome is not fully understood. Study teams should include someone with expertise in assessment when neurodevelopment is a study outcome. And then, of course, test companies should be allowing the sharing of translated and adapted measures between clinical and research teams, especially in lower resource parts of the world. Thank you. Any other questions? I know we don't have much time, but
You did some really good work also on ASD. Can you share with us a little bit of what?
so we haven't analyzed that yet. We just got that whole data set from Molly. And so, but if you, so just eyeballing it, it just doesn't look like they're, that in every domain, symptoms are reported to be way less severe. Symptoms are getting reported, concerns are being reported by parents, but not nearly to the severity level that we're seeing them. And so so the paper that we have in progress is going to look specifically at those things. And this was another reason why we wanted to have a lot of papers showing that the Mullen was working before the major papers come out, because we have this ASQ data too to say, like, okay, well, which one should we rely on? If we're talking about Zika or we're talking about microcephaly, are we going to rely on the ASQ or are we going to rely on the Mullen?
Well, the ASQ is a screening test.
Right, but you can have, we have had the criticism, like, you gave this performance-based test to kids who are totally unfamiliar with it, and you're disregarding the data you have from the parent who's actually living with the kid. So there are people who will say, oh, well, the unfamiliarity of the test for kids makes it so that caregiver report is more reliable. And so we knew that criticism was going to be coming. But any of us who were down there giving it, we knew which one was more reliable, right? Because it was the same thing happening with the PEDS-QL. You know, the kid wouldn't be speaking, and then the mom would be saying, oh, he speaks in sentences. Oh, yes, he can do this. Yes, he can do that. And then we'd say, well, we haven't heard him talk. How many words does he say? Oh, he says mama, papi, pacha. Like, well, that's not sentences. So, you know, I think there were often things that we saw in a Mullen and then were reported right after that were incongruent. And same with the PEDS-QL. I mean, I think I've told everybody this story that knows me, but we were at a house once and the mom's saying, oh, the baby had just been so sick and he had bronchitis and he was just in the hospital, he just got out, and he's all wrapped up, sleeping in his little crib, and the neighbor's burning tires, so you can hardly breathe between the heat and the tires. I'm like, oh, and the baby's just like this loud labor breathing, and the PEDS-QL says, has your baby been having trouble breathing? Nope. Has the baby had any respiratory problems lately? Nope. So we're like, and it was all this stuff that she'd been able to report really accurately in interviews. So there's something about it that's like not culturally translating once we put it into question form. That's been really hard. So, and I think it would be, if there was some way for us to figure out, like, of course we are getting a big percentage of them that are good and reliable, and if we could figure out which ones those were, and we might be able to start doing that when we do this next analysis.
Are you looking for any more tests, or you're pretty much done with kind of just using the Mullen, using the ASQ?
I've been done with using the ASQ for a long time, so we're not. I don't want to use that. Okay. I didn't think it was helpful.
Well, I think of the age range you're looking at, and I think of being a physical therapist in PEDS, the motor piece is probably where you're going to see a lot of change related to stunting or microcephaly, and so we use a lot of times with the younger population. Did you look at the Alberta Infant Motor Scale?
Well, we didn't want to for
just
this
one
for
area.
this for this one.
Yeah.
But our hope is to be able to maybe look at a new infant cohort, maybe follow this infant cohort. So we have a plan for like what the school age testing would be for sure. But it will be something I'm thinking about, certainly, of making sure that we're covering these things from 3 to 5 that at the beginning of the study we didn't think we were really going to need to cover, like gross motor skills, like measuring head circumference in those years, some of those things.
Well, what I like about that test, it's really only until a child walks. It's only normal until like 19 months when most children should definitely be walking, but it has pictures. And so in terms of the trainability of a variety of people in the community, it's all based on motor sequence in 4 different positions with pictures.
Yeah,
and
that's nice.
And it's really nice, and it has good psychometrics. So
yeah.
So I would think of that as far as like really relating that to microcephaly and stunting.
Right.
So there's a couple items on the Mullen that I would guess are culturally challenging to translate, like you talked about the sledding.
Mm-hmm.
But just from my own experience in going to some other low-income countries, things that require a young child to use like a crayon or other writing implement when they've never been exposed to that at all can be really difficult. Yeah. So,
and it really was.
Yeah.
And we thought a lot about that. We would have had to probably get rid of the fine motor test because so many of the items, once they're 3.5, right, are to color and to hold the scissors. But then, I mean, I did talk to quite a few people during that time when we were deciding what to do. And I think we still kind of landed on this idea of, well, there's, we knew we were testing for, all of this stuff is about, have you ever seen it? Like, did anyone ever read a book to you? Did you ever look at 4 things and choose, right? So you could make that argument for many of the tests. And the other thing I think, that was said to me when we were thinking about this was they're going to go to school. This isn't a culture that's so dramatically different from the U.S. So they're going to need to be holding a crayon or a pencil. We did more teaching of it. We didn't just hand them. We'd stick it in their hand, sometimes try to get them in a tripod grasp and help. But we decided not to get rid of those items because of the trajectory of where they were going to end up being. And I think because of this issue about, just exposure to all of that kind of stuff. Mm-hmm. And then for a lot of, I test in an international adoption clinic too, and I've been doing that for about 10 years. And it's often clear, they never sat down at the table and had to persist with anything that was hard. I mean, so there's all sorts of tasks that are related to the actual tasks that they've never done. And when you're working clinically, it's easy, right? Because you can make clinical judgments about what you think was maybe a deficit or weakness and what you think was lack of exposure and make your intervention plan related to that. And in research, it's just harder.
Mm-hmm. Mm-hmm. Do you think that was the most most challenging thing was to kind of adapt the questions or the assessments to make it culturally relevant, but also maintaining the what you needed to get out of it, I guess?
I think the most challenging part was training and getting it up and going.
Okay.
Because, here I have a fellow for 6 months and we had 2 weeks. And I went down there a lot and Desi and the rest of the team were highly competent, really good at assessment. But it was so hard. There were days to be so hot. And the kids, it was very, very common for them to be crying and clutching to their moms. Yeah. And we almost never had an assessment that we could not do. So that was the hardest. Okay, so we're not going to just give up. And every time the kid came back, some kids came back 2 times or 3 times, it was easier and easier and easier. But those first times when they were like, who is this lady? Yeah. They were, and it was hard, right?
Yeah.
Where I think a lot of clinicians could have been okay, this kid's not testable, but we're we cannot say something's not testable. And so they got really, really good at moving spaces, playing with them, but sometimes it would take 3 times as long as a regular assessment because they were working so hard to get the kid comfortable so that they could get good data and not trash.
Yeah.
Right?
Yeah, and sometimes we would even reschedule the assessment and go to their houses and spend a couple of hours just playing with them before we even started to assess.
Yeah, that's interesting. Because like here, maybe it's, kids going to like daycares and other places where they're just accustomed to like seeing other people, and I don't know, maybe there's
And they're
something
separating to go to school, right?
Yeah.
This morning I saw a 4-year-old and he was like, "Bye, Mom."
Yeah.
She went on the waiting room,
Uh-huh.
right?
Yeah.
But then most of these kids aren't going to school at that age either,
Yeah.
so separate. And we'd never asked them to separate, actually. Their moms were always in there.
Okay.
But right, it's just a lot of unfamiliarity.
Yeah.
Plus, it was not only a psychologist going there. We were a team of nurses, doctors, psychologists, all going in at the same time. So,
Sometimes they were getting blood drawn.
yeah.
Oh.
It was hard.
Yeah, that was definitely the hardest part.
Yeah.
Well, thank you very
Thanks
much.
for coming.
Thank you.